Welcome back to Favaloro Foundation University Hospital in Buenos Aires, in Argentina. So she's a very young lady, 52, with chronic type, actually A, aortic dissection with severe aortic dilatation on the thoracic aorta with more than 6 centimeters. I say A because it was repaired. So she suffered from the Marfan syndrome. She had a type A aortic dissection 10 years ago. She underwent surgical repair with aortic valve sparing, with Tyron David procedure, plus ascending an aortic arc replacement with an elephant trunk using the burst technique according to the surgical team description. She received an ascending aortic graft of 30 millimeters on diameter with the aortic arc of about 24 and an elephant trunk of 24 and also 24 in length. Found a significant dilatation of the thoracic aorta. So she also had a significant or severe thoracic deformation. So the ECG is quite normal, but with the first degree AV block, probably after the surgery, blood test a little bit anemic. And on the echo Doppler, she is also under clinical follow-up because she is suffering from significant aortic regurgitation. With a mild mitral regurgitation, with a preserved left ventricular ejection fraction. So this is the CT. You can observe there the significant, thoracic deformation with the pectum excavatum, a significant pectum excavatum. So there we observe the significant dissection after this elephant trunk. We made some measurements. The diameter is according with the surgical description, between 24 and 28 with a length of 2.5 centimeters. We observed there, in the previous slide, that we have at least 3 flaps there or 2 flaps there. It's an helical flap with significant deformation of the aorta from the very beginning with the significant angulation also in the zone 2, between zone 2 and zone 3. So there is with a little zoom where you can observe probably we have a landing zone between 2 and 3 after the subclavian of 2 centimeters. Our idea is to go exactly between this indentation and the subclavian artery. There you observe the severe dilatation of the aorta, which is the indication of treatment after 10 years. And on the right of the panel, a significant also scoliosis. And there is significant communication between the true and the false lumen there. There is quite a 3D reconstruction where we observe this flap with a significant communication in the proximal part, probably in the distal landing zone. There is a significant re-entry that we will try to seal, not only the entry tier distal to the subclavian, and then also the distal re-entry near the celiac trunk. So this is the vascular access. The right femoral artery is quite normal, straight without significant calcification. With a good diameter, almost 10 millimeters. So this is a 3D reconstruction of what we observe with this dilatation, especially in the aortic, distally to the aortic arc, but continuing until the transition of the thorax and the abdomen. So the strategy that we have already planned was the percutaneous access with the left subclavian preservation if we can, but we are going to go aggressively. We are going to go almost over the subclavian ostium. And then the plan is to implant probably 2 thoracic endografts. So the landing zone that is supposed to be there between 2 and 3, where the elephant trunk or surgical elephant trunk was deployed, and where we had to reconnect with the descending aorta. So the idea is that it was not necessary. Actually, we can comment then with Dr. Lev that we have a long experience and we have covered many subclavians and we haven't protected most of them. And to be honest, we never had a problem for covering the subclavia. When we have paraplegia or paraparesis or something like this, it was related to thoracoabdominal reconstructions and not to the subclavian artery. Probably the other option for this patient would have been something like this, a complete debranching from the ascending aortic graft, and then a TEVAR from the zone 0, covering the whole or the whole aortic arc, and then all the descending aorta. If we have a residual significant endoleak, probably this patient is going to be surgically repaired in a way like this. So probably more recently in our surgical group, what they are doing with this type A aortic dissection, compromising the aortic arc, is a surgery like this, introducing some new graft like the A beta graft, which has a longer elephant trunk, which is stented and is much more easy for reconnecting, and not the situation like we have today. We have already planned was to put a 7 French introducer sets on the left femoral artery. We have put here a pacemaker for pacing for deployment. And then we did crossover. There is a crossover with the pigtail. She has very normal artery. It was very easy to cross. Then we put the pigtail to do a puncture next under fluoro guidance. We select the entry point near in the upper part of the head of the femur. We have decided to put the pre-close. We have used ProStar. Many people like to use ProLite, like Dr. Lev. He likes the ProLite. And I like to use the ProStar when I am using over the 18 or 20 French sheath size. Previous view, we have problem because our plan was to put the 6 French on the left radial artery, but it was not possible, probably due to some trauma for the previous surgery. The radial artery was very weak, the pulse. So we are on the humeral with the 6 French introducer set, as you can see there. After that, there is the maneuver. You see the needles coming into the device. After that, I have 4 needles here, 4 threads here. The difference with the ProLite is that we have to do the knot in the surgical way before the final of the procedure. So after we put the ProStar, we put the 11 French sheath here, and we try next to go into the ascending aorta. So you can observe there a wire from below, which was impossible to find the true lumen. So we introduced a SIM catheter. The SIM was 1 or 2, 1. Preformed the catheter in the ascending aorta, as you can observe there, and then we pulled the catheter back. The tip of the catheter was inside the distal elephant trunk, and so we advanced a hydrophilic white wire distally, and then we introduced a snare from below. We snare the catheter. Unfortunately, we didn't show that I rotate the catheter to pointing out the snare, which was difficult to handle the snare, and it was much easier to handle the catheter from the brachial axis. We snare the wire, we pull the wire, and we introduce now a pigtail. This is from radial, and this is from femoral. Through this rail, we introduce this pigtail, which is now on the ascending aorta, and we are sure we are entering into the true lumen. Here is how we advance the catheter from below, and we pull the other catheter. We went into the subclavian, and then we connected the catheter a little bit more, and we push everything to be sure that the pigtail catheter is into the ascending aorta. First, that what we thought it was the true lumen in the inner part of the of the aortic arc is not that true. And as you can observe there, the tube is a little bit longer than expected. So probably we don't have to go too far distally against the subclavian artery. The bad thing is when you have such a long elephant trunk, sometimes would be extremely difficult to advance the TEVAR device. You also observe there the significant aortic regurgitation. So we have decided to use a device which has a free flow in the proximal end. So the reason why we have decided to use this device instead of the others without free flow in the proximal end is because for the Medtronic device, the deployment is much more precise when you have a distal free flow, because you can start deploying the device, keeping the free flow still attached to the delivery system, and when you are ready, then you deploy the proximal part. So the device we have chosen to begin with is the 32 by 200. We have reshaped the wire. This is the Landerquist wire, a very stiff wire. We have introduced a second bend, just trying to, configure or adapt to this heavily angulated aorta.
Fortunately, we have two vertebrals dominance, right and left, because the risk of paraplegia is high in this kind of patient. We are going to use two devices.
You are using the length of the aorta, you are covering. The possibility of preserving the left subclavian has been also shown to be important. And then to prevent any hypotension during deployment and after the procedure. And then also when we are especially treating these complex patients with thoracoabdominal aneurysm, our idea is to pacing high frequency like a TEVAR procedure, so we can stabilize the pressure or decrease the blood pressure during deployment. Now, this device is released quite similar to the TEVAR procedure. We can rotate for the beginning of the deployment, and then we can deploy a little bit faster.
Push it. So we are going to pace at 180 per minute in order.
Okay, we can stop there. Stop the pacing.
Pacing.
I think we are okay. We can release the nose cone here. No, we can keep doing. Dale, dale marcapaso. Dale. Beautiful.
Yeah.
Okay, perfect. I am very happy with this outcome. Subclavian is preserved. You can observe there on the floor the pigtail, so only the free flow is over the subclavian. We are perfectly engaged into the distal elephant trunk of the surgeons. We are going to prepare the second device.
I'm going to put another device, thinking in better remodulation and prevent expansion, because with only one device, you close the tear, isn't it?
Yeah, but we have your question is very good, but we have a huge dilatation there, and we will keep having flow there. So it's going to be pressurized. The idea is to seal if we can. Probably there. Yes. There.
Yes.
So if we identify where is, we don't need to engage. Let me show you up. Yeah. So we have a huge distance. So we are very close.
Yeah. Is it necessary to control cephaloric liquid in this kind of patient?
Well, in some patients, yes.
Subclavian?
But here we are not covering the subclavian, so I think it's not necessary.
It's not necessary.
So now I am close the device. So with this maneuver, I try to prevent any damage of the common femoral artery during retrieval. You have to be very cautious because we are going shiftless and we don't want to destroy the femoral artery. So Franco, be careful because it's gonna bleed. No, you have to hold near there. Once again, be careful.
Second product doesn't have free flow.
Yes, this second one is without free flow. So with this device, I'm going to be careful about the distal and landing zone and not so much about the proximal landing zone. Why? Because for sure we have space. We don't have to care too much about that, but this is at least the minimal overlapping that we have to have. Anyway, I think it's not going to be still the whole aorta. We are going to pacing.
Yes.
180. Is that? Perfect. And now I have to open the first part. Probably it's moving. So now I'm going to deploy under pacing. You see, this is the movement I want to prevent when I was doing the proximal part.
And then you finish manually.
Yeah.
Okay.
Now I'm going to pull it. And now it's time for the angio, and we can see what's going on here. I think we have a very nice outcome.
Yes, we have
minimal proximal end
proximal,
leak,
yes.
but we still are under anticoagulation. Let me show up, inject. I think this is also can be porosity.
Okay.
Because we have at least 3 struts overlapping the elephant trunk. We can do a balloon in there just to be sure everything is okay.
Yeah.
And then we can leave like this. Okay. I think it's perfect there. So you can observe the celiac trunk is completely open and patent. We are at the beginning of the abdominal aorta. We are not going to be too aggressive because I do believe this is porosity. Okay. So after anticoagulation reversion, it's going to disappear for sure. And we can show in the future the CT scan of follow-up. So we are going to pacing again. Let's go once. Vamos más, una más. Okay. Stop. And one more here in the connection. Una más. Okay. Stop. We are done. Just one touch there. Okay. Very gentle touch there.
Yeah, yes.
And let's go. And don't breathe. Stop breathing.
You're okay.
Let's go. Beautiful. Okay.
Okay. Better.
We still have some leakage there, but I think it's probably porosity because you don't see a feeling from
proximally.
Proximally. Yeah, sure. Hold. So please, Gustavo, retrieve the balloon, leaving the wire there. Okay. So now it's time to tie the knot. Revertimos por completo. Dr. Gustavo is gonna cross over with the balloon like we usually do for TAVI or any other procedure, we can hold the groin a little bit. We wait for the heparin reversion, inflate the balloon for 3 or 4 minutes,
Okay.
and then we are done.